Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. We'll be offering these 30-minute briefings regularly on Fridays at 12 p.m. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I serve as a member of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. Today, I'm joined by two guests. First, Dr. Jennifer Nuzzo, who's a senior scholar at the Johns Hopkins Center for Health Security and an associate professor at the Johns Hopkins Bloomberg School of Public Health. Jennifer will give an update about trends we're seeing in the COVID-19 data. Then we'll hear from Dr. Bill Moss, who's the executive director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update about COVID-19 vaccines. I'm now going to turn to each of our speakers for a brief overview. Jennifer, first to you. It feels like we're in a plateau in terms of new daily cases, at least in the United States. How should we interpret this in light of the Delta surge? Do you think that it's too soon to say that the curve is steadily decreasing?
Thanks, Lainie. I do think we are starting to see some decreases. This week, the national case count is down 16% from last Friday's total, so that is good news. Previously, we had been seeing a slowing in the increase in cases and then a bit of a plateau, but to see declines finally is very welcome. That said, not all states are seeing declines, and so we are still seeing about 10 states within the U.S. that are reporting increases this week. It seems like the geographic sort of center of where the cases are increasing is shifting a bit. We're finally starting to see declines in the southern states that had been so hard hit in the previous weeks. But we are seeing some increases now in sort of the West, Midwest, and the Northeast. In many of these states, though, the increases are much, much lower than what we had seen in the South, and that's likely due to the higher vaccination coverage in those states. So good news that we're seeing a decrease in cases. That said, always note of caution, we are still at dangerously high case levels, and the current case count is more than 1,000 times, it's 1,000% greater than what it was in earlier points of this pandemic, our lows. So we still have a long way to go to get back to where we had been. In terms of other indicators, so hospitalizations, we are also starting to now see some declines at the national level in terms of the total numbers of hospitalizations. The number of COVID-19 inpatients and number of patients in the ICU this week is down 8.1% and 6.8% respectively. So that's very much welcome, but again, not in all places. And so we're still seeing some hospitalizations increasing. About actually 19 states are reporting hospitalization increases this week. And again, compared to June, which was the lowest period of observed hospitalizations, today's inpatient numbers are up more than 400, about 430%. So we still have a long way to go. I expect if we continue to see sustained declines in our case numbers, eventually the hospitalizations will catch up, though. Deaths, is, again, one of our lagging indicators. And unfortunately, we are still seeing an increase in deaths, though I'm happy to say that the percentage increase in deaths occurring this week is lower than last week's. So last week, it was about 20% increase in deaths, and this week is just over 5% increase. Obviously, we don't want to see deaths occur when we have vaccines on hand to prevent that. But again, I think this will speak to something that, keep looking at deaths. And as we see the case numbers decline, I hope we will also see further declines in deaths. I do want to shift a little bit, though, to talk a bit about testing, because this is an area where we really need to focus our concern. Right now, the current national test positivity is falling, which is a good sign, but it's also still far higher than it has been in other points of the pandemic, and still higher than the WHO recommended benchmark. So we're at about just almost 8% test positivity nationwide. And I always look at test positivity as a potential early warning for how we may be missing infections, and that could potentially lead to case growth if we don't do something about it. When I see higher test positivities, that suggests to me that we're missing a lot of infections, and with test positivity being where it is versus where we had been earlier in the pandemic, that suggests to me that we need to cast a wider net to find the infections that are occurring so that we can stop transmission, have people stay home as long as they're not contagious. It's good news that test positivity is falling, but there are lots of reports, and my inbox certainly reflects this, of people really struggling to find a place to get tested, to access testing. They've tried to get tested and it's taking a really long time for their test results to come back. We know that people are having a very hard time finding the rapid tests, and manufacturers and retail sellers of those are having a hard time keeping them on the shelves. And that really just suggests that we are starting to miss more than we should. And so this is something that I think we absolutely must fix so that we don't see a subsequent rise in cases. And I'll just end sort of with the worldwide picture. Again, the case numbers are coming down globally, but the United States has been an outsized contributor to global case numbers. So some of these declines are in part due to declines here in the United States. We are seeing increases in various parts of the world. I think places to watch right now are Eastern Europe. Brazil is having very large increases and is in yet another surge of cases. Also, a few places on the African continent, we're seeing very concerning case increases. So very much a reminder that this is a global pandemic and still very much not over.
Thanks so much, Jennifer. Before I turn to Bill, I want to remind our audience, please submit questions for our experts. We'll move to Q&A shortly. I do see your questions coming in. Bill, gosh, so many developments in the last week or two. There's news about the Pfizer booster. We have a sense of when children aged 5 to 12 may be eligible for COVID vaccines, and also announcements about resources for global vaccination efforts. So with all of this news, what do you see as most likely to make a difference as we head into the fall and winter?
Yes, Lainie, it has been quite a week in the COVID vaccine world, and I ask our viewers to please buckle their seatbelts because it's been a wild ride. I think of the things you mentioned, perhaps a commitment to global vaccination is the thing that's going to make the biggest difference. But let me start with the announcement on Monday, which in the COVID vaccine world seems ages ago. But on Monday, we heard there was a press release from Pfizer regarding a phase 2/3 trial of the safety and efficacy of their vaccine in children 5 to 11 years of age using a 2-dose regimen. The dose was a third of the dose that older adults, those 12 and older, are getting, so 10 micrograms compared to 30 micrograms, administered 21 days apart. And so this was a safety and immunogenicity study. They did not look at vaccine efficacy. And the bottom line is that the antibody responses in this age group, 5 to 11 years, with the lower dose, particularly neutralizing antibodies, was very similar to what was seen in children and adults 16 to 25 years of age receiving the 30 microgram dose. So really comparable to what we call non-inferior antibody responses. And the side effects were very similar to what was seen in the older group as well. So again, this was a press release. Pfizer will be publishing the data and then hopefully by the end of this month be submitting the data to the FDA for emergency use authorization in this age group. And again, we go through this process where there'll be a review by the advisory committee to the FDA, then the FDA itself, and then we'll have to wait for recommendations from the advisory committee on immunization practices that would then be endorsed by the CDC. So again, our hope on the timeline for vaccines in children, for a Pfizer vaccine in children 5 to 11 years of age is perhaps by the end of October. And then, Moderna is a little bit behind on this, and we're hoping to see the Moderna trial data later this fall. The big news over the past week since we spoke last, Lainie, has been on the Pfizer booster dose. So I'm just going to try to quickly recap this. Last Friday, the advisory group to the FDA, the Vaccines and Related Biological Products Advisory Committee, met and recommended offering a booster dose to 3 groups: people older, 65 and older, and those who are 16 and older, who are at high risk of getting severe COVID, or who work in settings that make them at higher risk. Now, the Pfizer application was actually for everyone older than 16 years of age. So this advisory committee to the FDA kind of narrowed down, rejected the Pfizer claim, but and narrowed down the target population. Then what we saw is the FDA coming out with their formal recommendation. Remember that on Friday was an advisory committee. So late on Wednesday, the FDA issued an emergency use authorization of the Pfizer-BioNTech vaccine, single booster dose, to 3 groups: individuals 65 years and older, compatible with the advisory committee; individuals 18 years of age through 64 years of age for at high risk of severe COVID. So these are those underlying comorbidities. And then individuals 18 through 64 years of age who are at high risk through institutional or occupational exposure. That was the FDA's emergency use authorization. Again, this applies only to the Pfizer-BioNTech. And you know, that last group is not well defined. Janet Woodcock, the acting director of the FDA, said that this could apply to healthcare workers, teachers, grocery workers, and those in homeless shelters or prisons. So a very wide group. And then the big news this week, Wednesday and Thursday, the Advisory Committee on Immunization Practices, which is the advisory committee to the CDC that actually makes the recommendations. The FDA is the regulatory agency. The CDC makes the recommendations, which are non-binding. They are recommendations. And so the Advisory Committee on Immunization Practices just yesterday afternoon voted on 4 recommendations and approved 3. The first one, that booster doses should be recommended for individuals 65 years or older and long-term care residents. And this was a unanimous decision, 15 votes in favor, none against. I think this is where the evidence is clearest, that we have seen a reduction in vaccine effectiveness, including for severe disease, hospitalization and death, but more so for infection, in individuals older than 65. That was the most, that's where we have the most evidence. The second recommendation voted on by the Advisory Committee on Immunization Practices, a booster dose for those 50 to 64 years of age with underlying medical conditions. So this is different than the FDA emergency use authorization. The ACIP narrowed that age group to 50 to 64 years of age. Now, the third recommendation is a little more subtle, and this is recommending a booster dose for those 18 to 49 years of age with an underlying medical condition. Again, that places them at high risk of severe COVID, but based on individual benefit and risk. And this is a tricky one because it's hard to know exactly how one would operationalize this and how it really is different than the second recommendation for those 50 to 64 years of age with underlying medical conditions. And it comes out of their what they call their evidence to recommendations framework, which allows for more individual level decisions on who should get a booster dose. All 3 of those recommendations were approved. That second one, at a vote from 13 to 2 opposed. This last one, 9 in favor, 6 opposed. The last recommendation, which was actually not approved by the Advisory Committee on Immunization Practices, that's the one around a booster dose in those individuals who are at high risk of exposure in their workplace or occupational setting. Now that vote was 9 in favor of, 9 rejecting, 6 in who were approved that. So we had this very tight voting on these. Now let me, so that's the vote. That's where we ended up yesterday afternoon after ACIP. Now let me, these are just kind of offer a brief critique here. These are interim recommendations, and they very much acknowledge that there's still a lot more data that needs to come in, and we could see these change over time. Now, Dr. Scott Gottlieb, the former FDA commissioner in the Trump administration, spoke last night and said that this was the biggest difference he was aware of between an FDA authorization or approval and CDC guidelines, where we really saw these differences. And this creates some obviously kind of challenges in messaging this, but also in implementing this. And very interestingly, because all these vaccines are purchased by the US government, providers are obligated to follow CDC recommendations. Otherwise, they do not receive the legal liability under the act under which these vaccines are purchased. So it's really the CDC, in this case, because there's no private purchasing of vaccines, providers are really obligated to follow the CDC recommendations. Now, why was there such controversy about some of these? So in terms of those individuals with underlying medical condition, some of the ACIP members argued that we really don't have the evidence suggesting that these individuals have waning immunity and thus would benefit from booster doses. It may be that that's the case. We just don't have the evidence like we have for those older than 65 years of age. So some argued that, by really pushing for booster doses, we're really undermining confidence in what the 2-dose vaccine schedule do. And we want to, as public health messengers, really emphasize that people who are fully vaccinated with 2 doses, are highly protected against severe disease, hospitalization, and death. And then lastly, another thing that played into this was some ACIP members express concern that we don't have all the safety data that we need, particularly in those younger individuals where there's a potential, concern, at least for the myocarditis and pericarditis that we saw after the 2nd dose of the mRNA vaccines, again, particularly in younger males. In my kind of, listening to the discussion, I also think there are flaws in this process, and I don't think there was enough discussion, particularly after the recommendations were kind of framed, on how one would implement these, how to operationalize these. What are the frontline vaccinators and providers, the doctors, the nurses, the pharmacists? How are they going to interpret this and enforce some of this? This is also critical for public understanding about these. And there needs to be more discussion about how do we communicate this to the general public. Now, the big news early this morning, after midnight last night, was that the CDC director, and she has the power to do so, basically overruled the rejection of that 4th recommendation, and basically said that the CDC recommends vaccines for those individuals who are at high risk of exposure in their occupational workplace. And so this opens the door then for healthcare workers, for example, to get a booster dose. But again, there's a lot of ambiguity and room for interpretation of these recommendations that really makes it, can make it confusing and going to be a challenge to implement. The CDC directors, Dr. Walensky's, change does align CDC policy closer with the FDA policy, so we have less of a discordance there. And it also obviously is more consistent with what President Biden's announcement was several weeks ago to provide booster doses to a broad, a large number of Americans. Now, what was not on the table really is the very important ethical dilemma of providing booster doses to people in the United States when there remain these gross global vaccine inequities. And there have been a lot of statements by very prominent people, including many from the World Health Organization, who really claim that we should not be, that high-income countries or wealthy countries should not be providing booster doses until we vaccinate more of the world's population. Now, we did hear this past week on Wednesday around the United Nations General Assembly meeting that President Biden announced that the United States would purchase an additional 500 million doses of the Pfizer vaccine, in addition to an already pledged purchase of another 500 million doses. The U.S. has already donated about 160 million doses of COVID-19 vaccine. So that would bring the U.S. total to about 1.1 billion by the end of 2022. Now, we've talked before in this setting, Lainie, that if the goal is to vaccinate 70% of the world's population, that's going to take about 11 billion doses. Already about 6 billion doses have been administered. Gross inequities, more than 80% in high and upper middle income countries, less than 1% in low income countries. It's certainly good that the United States is pledging to buy another 500 million, but still much more needs to be done by the United States and by other wealthy countries throughout the world to vaccinate the world's population. And I'm going to push once more, Lainie, my idea that the United States should donate 5 doses for every booster dose administered. Thank you.
Thanks, Bill. Wow, you were not kidding about the number of things to be covered in your update. I am exhausted on your behalf. And I'm going, in a moment, I will turn to the Q&A. Bill, you're not done yet. We have a lot of vaccine questions coming in. But before I do that, I do want to remind our audience that you can subscribe. You'll see a banner on your screen to our weekly newsletter called The Week in COVID-19. It is a great way to get the latest information about the virus itself, variants, vaccines, and it will be delivered to your inbox every Monday. So now Bill, I'm sorry, that was a 20-second respite for you. I'm going to turn now to the questions coming in. First question for you. For individuals that are fully vaccinated and who subsequently had a breakthrough case of COVID, how should they be thinking about getting a booster?
Yes, so it's a very good question, and we know that if they've had a breakthrough infection, that serves as a booster. We don't know quite as much about that scenario, but I would kind of look at it, in terms of other risk factors for exposure, risk factors for severe disease, and kind of weighing those benefits. I'll be very frank, we don't have guidelines or recommendations on this kind of scenario. In general, what the CDC has said is that people who've had COVID-19 should be fully vaccinated after that, because we do know that breakthrough infections are more common, almost 2.5-fold times more common after a natural infection than after vaccination. We do know that the immune response after natural infection is much more variable in terms of its duration and magnitude than after vaccination, but that does serve as a booster dose. So exposing the immune system to the virus again. So I would weigh that in the context of an individual's risk of exposure and risk of severe COVID, whether or not they should get a booster dose.
Thanks, Bill. Sticking with you, what are your thoughts about mixing and matching in terms of the booster? So for individuals who received a Moderna or a J&J vaccine as part of their original vaccination, what does that mean in terms of Pfizer and getting a booster?
Yes, this too is a really important question, and it came up several times in the discussions of the Advisory Committee on Immunization Practices. And I think everyone is really uncomfortable that these recommendations are really really for people who've gotten 2 doses of Pfizer and would get a 3rd dose of the Pfizer vaccine. That's because it's the Pfizer BioNTech that's made the application to the FDA, and we need to wait for Moderna and Johnson & Johnson or Janssen to apply for authorization for a booster dose for their vaccines. That said, there is an ongoing trial looking at it's actually a Moderna dose, booster dose for individuals who received either a first Moderna, Pfizer, or J&J. There's a small ongoing trial, so we'll have more information on that. There's a larger trial, or I should say, there's more data coming that has come out of the UK comparing AstraZeneca vaccine. Different vaccine. It's an adenovirus vectored vaccine, so somewhat similar to J&J. It's a different vector, followed by a Pfizer that shows a very robust immune response. So the bottom line is that there is insufficient evidence right now for the FDA and thus also for the CDC to make recommendations on mixing. There is data that will be coming forth, and I think everyone recognizes the urgency to resolve this issue and have recommendations around booster doses for those who receive the Moderna, and I would say particularly for those who receive the single-dose Johnson & Johnson. It's just that we don't have the evidence yet where the regulatory body is really comfortable making a decision.
Thanks, Bill. Still sticking with you. Sorry, Jennifer, hang on. Bill, for the Pfizer booster, is it the same formula as the first and second shots in the series, or is this something new that's been formulated to address the Delta variant?
Right. Another really good question. This is the same vaccine. So it's a 3rd dose. It's the same dosage. It's the same same formulation of the vaccine. I know with Moderna, they are looking at, for their booster dose, a lower dose vaccine. So Moderna vaccine actually has a much higher dose. It's 100 micrograms. And for their booster dose, they're looking at the 30 microgram. But for Pfizer, same vaccine, same formulation, same dose. The company has developed a reformulated vaccine that does target the Delta variant, but that's not what we're talking about here.
Thanks, Bill. I will now give you a break. Jennifer, in our last minute, how are breakthrough infections being tracked? Is there someplace public to go for them? Where are the gaps?
Yeah, so they're being tracked in terms of breakthrough hospitalizations and severe illness. That is the thing that CDC is tracking. But in terms of just if you have been vaccinated and you test positive and you don't wind up in the hospital, whether that's being tracked and the extent to which that's being tracked really depends on the state that you live in. Many states don't even have a ready ability to know the vaccination status of who's being hospitalized. So they have to, when hospitalizations occur, go and track that information down. And you can imagine it's even harder to get that information for people who, test positive at some clinic where that information may not have been asked in the first place. So generally, breakthrough infections are not being tracked. I will just say as a last minute, I don't love that term breakthrough infections because I think it implies that the vaccine should prevent you from being infected. Vaccines aren't force fields. They don't repel the virus from your body, but they do teach your body how to react once the virus enters your cells. So it should be really breakthrough disease as far as I'm concerned.
Yes.
Thanks, Jennifer. I'm going to wrap, but I see that Bill heartily endorses what you just said.
Yes.
Well, we are at 12:30 exactly, so I will thank Jennifer Nuzzo and Bill Moss for joining me today and give a big thank you to everyone who joined us and especially to those who submitted questions for our experts to answer. As always, this briefing will be archived and available on coronavirus.jhu.edu. As a reminder, we do offer these 30-minute briefings regularly on Fridays at 12 p.m. We'll be back next Friday, October 1st at noon with this briefing. I'll look forward to seeing you then. And until then, thanks and stay safe.